I'm Dr. Claire Waddington and I'm going to talk today about COVID-19 vaccines. So what's the current state of play with this? As many of you are aware, COVID vaccines are probably the most promising route to bringing the COVID pandemic under control. Because of this, massive efforts have gone into developing vaccines for COVID, and extraordinary and unprecedented progress has been made in a very short time frame. We currently have 13 candidates in clinical trials, over 150 other candidates in preclinical testing, and in the last couple of weeks we've seen data published from 4 of the early candidates showing that they are all safe and that they can all generate an immune response in humans. In vaccine terms, this is incredibly rapid progress. It typically takes more than 10 years to develop a vaccine. So what's allowed us to develop these vaccines so quickly? One of the major things that has helped has been the early availability of the entire genetic sequence of the virus, which was published on January the 11th. This allowed us to generate prototype vaccines directly from the genetic code itself, a process that took only a couple of weeks for the earliest of the vaccine candidates. Scientists were also able to study the detailed structure of the virus very early on, and were able to show that one of the surface proteins on the virus, the spike protein, was the protein that the virus used to attach and invade human cells. Further, they were able to show that human antibody could bind to this spike protein and thereby block the virus from invading host cells, the first step to generating an infection. So very early on, we had both the genetic sequence that we could use for vaccine production and the data that showed that if we could generate antibodies to the surface spike protein, it was likely to protect against infection. The other important accelerating factor for vaccine development has been CEPI, the Coalition for Epidemic Preparedness and Innovation, that was set up after the Ebola outbreak in West Africa, with the explicit purpose of being able to respond with vaccines to outbreaks. With the Ebola outbreak, developing a vaccine was significantly delayed by a lack of funding mechanism and strategy for vaccine development in outbreaks, and CEPI was created as a global body for vaccine development specifically to be prepared, respond to, and have a sustainable solution to outbreak settings. Importantly, their initial pre-pandemic work looked at some target vaccines that they thought may lead to outbreaks in the near future, and you'll notice that this included MERS-CoV, which, as you're probably aware, is also a coronavirus. This gave us a significant head start in thinking about how we might develop vaccines for coronaviruses. So in terms of the vaccines themselves, what approaches are being used? Well, almost all vaccines that are currently being developed are aiming to generate an immune response to this bit of the virus, the spike protein. This is a surface protein, and that's the target because, as I said before, that's the bit of the virus that binds and allows viral entry into host cells. And we have seen clearly in vitro that we can block this antibody, then we can block viral cell entry and hence infection. It's also one part of the virus that we mount a natural immune response to, and that tells us that it's likely to be important in immunity to the virus. So if they're all using the spike protein as a major antigen, why so many candidates? So although most vaccines are taking this target of the spike protein, there are major differences between the vaccine candidates in terms of the approach and vaccine technology they're using to make the vaccine and generate the immune response to this spike protein. Very few vaccine candidates are based on more traditional approaches. These are techniques that have been used for decades, such as using killed whole cell vaccines or live attenuated vaccines. But in the context of COVID, these approaches are actually quite challenging because they require infectious virus to be produced. And in the case of live attenuated vaccines, they will need a lot of safety data to show that they won't in fact cause illness themselves, and are particularly a source of concern when potentially giving them to immunocompromised patients. So a lot of COVID vaccine candidates have instead focused on these more novel technologies, such as delivering genetic code of the spike protein directly to the immune system through RNA and DNA vaccines, and bypassing the need to grow the vaccine, or using other viruses to deliver the vaccine antigen. The Imperial University vaccine, which you may have heard about, for example, is using mRNA technology. So they are injecting the RNA of the spike, the message that's translated into protein by the cells directly, and providing the blueprint for the spike protein. It's delivered into muscle using fat droplets as a delivery mechanism that allows muscle cells to take it up. And these cells then start expressing high levels of the spike protein, and the immune system sees them as foreign and makes potent antibodies to it. The viral vectored approach is the one that the University of Oxford vaccine is based on, and that's the vaccine you've probably heard about in the media that is being trialled here in the UK, including in Cambridge. If this vaccine is proved effective, it is the vaccine that is likely to be rolled out first in the UK. So let's just discuss that vaccine in a little more detail. This vaccine's formal name is ChAdOx1, and it is a non-replicating simian adeno-vectored viral vaccine expressing the coronavirus spike. So let's take that apart. This vaccine uses adenovirus as a carrier, a vector, to carry the genetic code for the spike protein. Adenoviruses can infect human cells, and we can make use of that as a mechanism to carry the genetic code into host cells. They've used a simian virus, i.e. one that was originally isolated from a monkey, and that is so that people don't have pre-existing immunity to this particular adenovirus. It is a non-replicating viral vector, and this means that the live virus in the vaccine can infect cells after vaccination, but then when it's inside that cell, it can't make any more copies of itself, so it just infects the first cell it gets into. When it's inside the cell it is infected, it produces the spike protein antigen that we want to get the immune response to, and this is seen by the immune system and generates an immune response. Before April of this year, this type of vaccine technology had been used in well over 6,000 people for different diseases. So ahead of this pandemic, we already knew a lot about how much of this vaccine behaves in terms of its safety and immune responses. And encouragingly, having moved rapidly into early phase trial, these data were published in the last couple of weeks in The Lancet, and what they show is that compared to the comparator vaccine, in this case MenACWY, we get strong immune responses to COVID after 28 days following the vaccine. In a very small number of participants, just 10, they actually also looked to see whether they could boost this immune response, giving a further dose of the vaccine, and that as well was successful, although, as I say, limited numbers. And further, what you can see is that these immune responses in the vaccine candidates were fairly equivalent to those seen in people that had recovered from natural infection. So all of this was very encouraging, and it was also described as being safe and well tolerated. However, there are still many challenges ahead in terms of vaccine development. First is the problem of needing to demonstrate efficacy. So although we have data that show that the vaccine is safe and generates good immune response, we haven't yet shown that it definitely prevents infection and illness. And to do that, we need to follow up the volunteers in the trial and compare how many of them get disease compared to those who are in the control arm with the MenACWY vaccine. However, when community transmission of COVID falls drastically, as has occurred with lockdown, it can be quite challenging to see the number of infections necessary to actually see a difference between the two trial arms. Another problem is that we don't actually know what optimal immunity to COVID looks like. So as we show in this diagram here, immunity isn't black or white. It is more of a continuum from not having any immunity through to having an immune response that is actually part of the problem. And this, in the context of COVID, is what you might have heard termed antibody-dependent enhancement. And this is a theoretical risk whereby antibody can actually augment the harmful effects of the virus. This potential immunopathology was seen in the early vaccine development against the original SARS virus vaccines many years ago. And although we don't think it's going to happen with COVID vaccines for various reasons, we have to be absolutely certain. And in the context of needing to be careful about the type of immune responses we generate, it may well be that initial vaccines more target the middle part of this continuum, which either reduce severity or duration of illness, but not prevent it entirely. And we may see vaccines like this being used initially, with more potent vaccines replacing these early vaccines as we gain a further understanding of the disease. We also don't know the duration of immunity that we can expect, and therefore whether we're going to need to provide boosters down the line. And we also don't know whether this virus is going to mutate, which, if it mutated significantly, could mean that the vaccine efficacy was reduced and that we may have to provide future iterations of the vaccines like we do with flu vaccines. I'll just leave you with one brief thought of an approach that may help us tackle some of these unknowns, and that is to do controlled human infection models to accelerate vaccine development. Controlled human infection models involve using human volunteers and exposing them to the illness of interest after vaccination to see whether the vaccine works and how it works. They've been widely used for vaccine development for all kinds of diseases, as can be shown here, and many thousands of volunteers have volunteered for these studies and helped accelerate vaccines. We're currently exploring the possibility of doing this for COVID with the Wellcome Trust, and hopefully we may get to the point where we can use such approaches to accelerate development. That's all from me. I hope you've enjoyed this talk, and thank you for listening.